Hello, everyone, and welcome to our module on sleep disorders. So, we're going to start by talking about insomnia, which is a very common clinical problem. And the definition of insomnia is difficulty falling asleep, staying asleep, or waking up too early and being unable to go back to sleep. Insomnia is classified based on how long it's been occurring for. So, short term insomnia is insomnia that's been present for less than 3 months. And then chronic insomnia is insomnia that's been present for 3 months or longer. For short-term insomnia, the treatment usually involves counseling patients about sleep hygiene, which we're going to talk about in just a second, and only using meds if the symptoms are severe. Generally, meds are avoided for short-term insomnia because it often goes away on its own. For chronic insomnia, patients are also counseled about sleep hygiene, but then cognitive behavioral therapy for insomnia, or CBTI, which we'll talk about in a minute, is the first-line therapy for chronic insomnia. This has been shown to be more effective than drugs and other interventions. There are drugs that can be prescribed for chronic insomnia, and we'll talk about these shortly, but they are considered second line or only for use in severe cases of chronic insomnia. Okay, now we're going to talk about the treatments for insomnia, and I've already touched on this, but when patients present with symptoms of insomnia, one of the things that's always done, no matter how long the insomnia has been present for, is to advise patients to try and practice good sleep hygiene. So let's talk about what this means. So good sleep hygiene means a consistent sleep schedule and bedtime routine. Patients should have a comfortable sleep environment. They should limit stimulants, especially close to bed, things like caffeine and smoking. They should try to get regular physical activity, limit their naps during the day, and also limit their screen time, especially close to bed. Just doing these things here can help some patients who have short-term insomnia. And then I also already mentioned this, but cognitive behavioral therapy for insomnia, or CBTI, has emerged as the first-line treatment for most patients with chronic insomnia. There are drugs that can be prescribed for chronic insomnia, but behavioral therapy has been shown to be superior in a lot of clinical studies. I'm going to want you to know this for your boards, that CBTI is the first-line therapy for patients with chronic insomnia. Okay, now I'm going to talk about the medications that can be used for insomnia. And the first thing to know about all these drugs we're going to talk about in the next few slides is that you have to be very careful in prescribing them for the elderly. They are associated with confusion and falls, and they are on lists of medications that can cause delirium symptoms in patients who are elderly, which I talk about in other videos. One of the drugs we're going to talk about is Ramelteon, and you should know that this is the safest option for older adults. We'll talk about it in just a second. Another group of drugs we'll talk about are the so-called Z drugs. They all have a Z in their name, so these are drugs like Zolpidem, Zaloplan, and Azapaclone. And then lastly, we'll talk about Sufrexant, which is a special sleep drug that has a unique mechanism of action. It's an orexin receptor antagonist. Okay, we'll start by talking about the drug Ramelteon, which is a melatonin receptor agonist. This drug binds to melatonin receptors like MT1 and MT2, which are found in the suprachiasmatic nucleus of the hypothalamus. And so like the naturally occurring hormone melatonin, these drugs bind to melatonin receptors and cause patients to feel sleepy and fall asleep. Super important thing to know about this drug is that it doesn't affect GABA receptors like the Z drugs, which we're going to talk about in a minute. That means that it generally doesn't cause daytime sedation and cognitive impairment. It's also not known to cause dependence and withdrawal. And so this is why, as I mentioned earlier, this drug is the first-line drug in the elderly because it's generally safe, and it's because it doesn't interact with GABA receptors. And really, this drug has few major side effects. Some patients complain of minor symptoms like dizziness, fatigue, and nausea, but this is generally considered a safe option for patients who have chronic insomnia. Okay, next we're going to talk about the Z drugs, which are these 3 drugs I mentioned here. They all have a Z in their name, and they're all used for the treatment of insomnia. This class of drugs is also called the non-benzodiazepine hypnotics, and they get this name because they bind to the GABA receptor, the same receptor that benzodiazepines bind to, but they have a different chemical structure that's distinct from benzodiazepines. These drugs preferentially bind to the BZ1 receptor, which is a subtype of GABA receptors. And because they mostly bind this subtype, their effects are slightly different and safer than benzodiazepine drugs. So first of all, the Z drugs have a lower risk of patients developing tolerance to the drugs. They also have a lower risk of patients becoming dependent on the drugs compared to benzos. Also, because they bind this BZ1 subtype of receptor, they disrupt sleep architecture less than benzodiazepines do. But then lastly, you should know, especially for board exams, that because they bind the GABA receptor just like benzos, they can be reversed by the drug flumazenil, which is a drug that can be used to reverse overdose of benzodiazepines. This drug also works for overdose of the Z drugs. Besides being safer than benzodiazepines, these drugs are also useful for insomnia because they have a short duration of action. They're quickly metabolized by the liver, and this short duration of action makes them good for sleep onset insomnia, patients who have trouble falling asleep. These drugs decrease sleep latency, which means the time from when you close your eyes until you actually fall asleep. And then also because they have a short duration of action, they usually have minimal symptoms the next day like drowsiness. The adverse effects of the Z drugs are similar to the adverse effects of benzodiazepines, they just occur less frequently. So benzodiazepines and Z drugs are central nervous system depressants, so they can depress central nervous system activity, and that can cause you to develop ataxia and lose your balance. That can cause confusion, and that can sometimes cause next day drowsiness. The main benefit of the Z drugs over benzos is that they cause these side effects less frequently than benzos. I already mentioned this, but these drugs have a short duration of action, so they're famous for having less day-after effects than benzos. Patients aren't so drowsy the day after taking one of these meds, and they have less psychomotor depression, which basically just means loss of coordination and alertness. These drugs do have one special side effect that patients will bring up to you when you prescribe them, and that is anterograde amnesia. So patients who take these drugs can forget events after they take the drug but before they fall asleep. So for example, if a patient takes one of the Z drugs and has a conversation with their spouse or partner before bedtime, many times the next day they won't remember that conversation. That's anterograde amnesia. This is something that commonly happens with benzodiazepines when patients take benzodiazepines before they go to sleep, but it can also happen with Z drugs, although it's less common. Okay, our last drug for insomnia that we'll talk about is suvorexant. So suvorexant is an antagonist to orexin receptors. So let's talk about what orexin and orexin receptors are. So orexin receptors, as the name implies, bind orexin, which is also called hypocretin. It's a neuropeptide that's produced by the lateral hypothalamus. And you find these orexin receptors throughout the central nervous system. And when orexin binds to these receptors, that helps to regulate arousal and wakefulness and also appetite to some degree. So when you block these receptors with suvorexant, patients get sleepy, and that's why this drug works for insomnia. Some of the adverse effects I've listed here, so patients can have daytime sleepiness if the effects of the drug persist into the next day. This drug often causes headache. Some patients have abnormal dreams or nightmares on this drug. And then it's also been associated with sleepwalking, which is a parasomnia we're going to talk about later in this video. Super high yield thing to know about suvorexant is that it's contraindicated in narcolepsy. Narcolepsy is a sleep disorder we're going to talk about later in this video, but the underlying cause of narcolepsy is orexin deficiency. So if a patient has narcolepsy and they're deficient in orexin, and then you block orexin receptors, you can amplify their symptoms of narcolepsy. And so the only absolute contraindication to suvorexant is patients who have narcolepsy. A couple of other things to know about this drug. It's metabolized by the liver, so it's avoided in patients with severe liver disease because the effects can be excessive. Also, cytochrome P450 inhibitor type drugs can boost the level of suvorexant, just like they can of other drugs that are metabolized by these enzymes. And then lastly, like Ramilton, which we talked about earlier, suvorexant does not affect GABA receptors. This means it has a limited risk of patients becoming dependent on the drug for sleep. It also has less effect on sleep architecture because drugs like benzos that bind GABA receptors can disrupt your sleep architecture. And then also it has a low risk of withdrawal. Okay, moving on. Next, let's talk about parasomnias. So these are disorders that occur during sleep where patients develop either undesirable physical events, things like movements and behaviors, or unwanted experiences during sleep, things like emotions and dreams. Parasomnias are classified into two groups. There are those that occur during rapid eye movement sleep, so-called REM-related parasomnias, and then there are the NREM-related parasomnias. There are two REM disorders that I think are worth knowing about. The first one is sleep paralysis. This is where the patient wakes up from sleep but is unable to move. So in the video on sleep physiology, I talk about how during REM sleep, patients develop atonia and they're paralyzed. So if someone wakes up in the middle of REM sleep and doesn't recover their motor function, they will have sleep paralysis. This is a very scary phenomenon. Usually it's short-term and resolves after a few minutes. Another important REM disorder is a nightmare disorder. So this is when patients wake up fully oriented, but they're yelling and screaming from a nightmare. And once again, if you've watched the video on sleep physiology, you know that we dream during REM sleep. So when patients wake up and they still have the experience and the feelings from that dream, that's what can lead to these nightmare disorders. A key feature is that the patient awakens. So if the patient awakens, that's probably a REM disorder. The NREM disorders, which we're going to talk about in a minute, are where patients remain asleep as they're behaving abnormally during a sleep problem. But in both of these REM disorders, the patient wakes up, Problem is some element of REM sleep is persisting after they wake up. Either it's persistent paralysis or it's sensations from the nightmare. Okay, the NREM disorders are disorders of arousal during sleep that occur during non-REM sleep. Usually they occur during N3 sleep, which I talk about in the video on sleep physiology. This is our deepest type of sleep, and most of our N3 sleep occurs earlier in the night. That's when we have more N3 sleep, and so that's when these NREM disorders often happen, earlier in the night. The REM-related disorders, like those ones on the last slide, usually happen later in the night because that's when we have more REM sleep. A key feature of these NREM disorders is that the patient is not fully conscious. This is going to distinguish them from the REM disorders we talked about in the last slide. So a patient having one of these NREM disorders is not going to fully awaken, and the next day they're not going to recall the arousal activities because they were still in a state of sleep during the behavior of the NREM disorder. There are 3 NREM disorders that I think are worth knowing. I've listed them all on this slide. So sleepwalking is fairly straightforward to understand. That's when the patient gets up out of bed and walks around, but they're not awake. They're in usually stage N3 of deep sleep, but yet they are out of bed and walking around. Another NREM disorder is sleep terrors. So in sleep terrors, patients sit up screaming, they're inconsolable, but they are not fully awake. And this is important. If they're fully awake, it's probably a nightmare disorder like I talked about earlier. But if they're not fully awake, it could be a sleep terror. Because these patients are asleep, they won't remember this the next day, which is another thing that distinguishes this from the nightmare disorders we talked about earlier. And then finally, sleep-related eating disorder is another NREM disorder. So in this condition, patients are not fully awake. They're only partially aroused, but they get out of bed and they eat. And often they eat really bizarre foods like raw meat or coffee grounds. I had one patient I met who had this disorder, and she told me that she would wake up in the morning and her whole kitchen would be destroyed because she had cooked an entire meal for herself while she was asleep. And most of these NREM disorders occur during N3 sleep. Like I told you before, that's our deepest stage of sleep. You should know, however, that for sleep-related eating disorder, there's some evidence that it also occurs in N2 frequently as well as N3. Okay, moving on. Next, let's talk about narcolepsy, which is a disorder of sleep-wake cycles. So patients with narcolepsy get very sleepy during the day when they should be wakeful, and they get very awake at night when they should be sleepy. And the underlying cause of narcolepsy is decreased production of neuropeptides. I mentioned this earlier when we were talking about drugs used to treat insomnia. It's been well described in the basic science literature that patients who have narcolepsy underproduce orexin A, which is also called hypocretin 1, and orexin B, which is also called hypocretin 2. These are both neuropeptides produced by the hypothalamus. And one of the ways we know that these neuropeptides are part of narcolepsy is that you can actually get a blood sample from the CSF, and it will have low levels of hypocretin 1. We'll talk about this in a minute when we talk about diagnosis. And then the reason that these neuropeptides have low levels in patients with narcolepsy is because there have been neurons that have been lost in the lateral hypothalamus that normally produce orexin A and B. In terms of demographics, narcolepsy occurs in young patients, usually patients in their teens or early 20s. It occurs in men and women equally, and most cases are sporadic, so usually there won't be a family history of narcolepsy. So the dominant feature of narcolepsy, and the one that usually brings patients to medical attention, is daytime sleepiness. These patients are exhausted and falling asleep during the day, and that usually causes them to go and see a physician. Technically, patients have to have at least 3 episodes of daytime sleepiness per week for 3 months in order to meet criteria for narcolepsy. They also will complain that they fall asleep during the day inappropriately, so patients with narcolepsy can become exhausted and fall asleep at their desk, like this man shown here. These patients classically have what's known as sleep attacks, where they suddenly fall asleep within a minute or two during the day when they should be wide awake. And then besides the sleepiness features, there are other features of narcolepsy, and the way to understand these other features is that they all involve features of REM sleep intruding into wakefulness. So there are 3 things that can happen under this category, and that's cataplexy, hallucinations, and sleep paralysis, and we'll talk about all of these now. So cataplexy is a sudden loss of muscle tone, and this normally happens during REM sleep. During REM sleep, atonia or loss of muscle tone is a normal development. What happens in narcolepsy is that the loss of muscle tone occurs during the day when patients should be awake. And when this happens, this is called cataplexy. In patients who have narcolepsy, the sudden loss of muscle tone is often triggered by strong emotions. So in a board question, they're often going to describe someone who is laughing and then suddenly collapses to the ground from loss of muscle tone, or someone who has this happen when they're surprised or they get angry at someone else. In some cases, it just involves the facial muscles, so patients will simply have their jaw drop after they are laughing. That could be evidence of cataplexy. but classically it's described as full body collapse where the patient collapses onto the ground with no muscle tone. During episodes of cataplexy, consciousness is preserved, and the loss of muscle tone can last for a few seconds to a minute or so. And as I said before, the reason this develops in patients with narcolepsy is because the atonia that's normal during REM sleep is now occurring during periods of wakefulness. Hallucinations are another feature of narcolepsy. Often patients have visual hallucinations, although sometimes they can have other hallucinations like tactile or auditory. They're often vivid and very frightening, and usually they occur when patients are falling asleep. These are called hypnagogic hallucinations. Less commonly and very rarely, patients can have hallucinations when they're coming out of sleep and just awakening. These are called hypnopompic hallucinations. And just like with cataplexy, the reason that patients who have narcolepsy experience hallucinations is because they're having REM sleep features that intrude into wakefulness. So the dreams that they would normally experience during REM sleep are happening when they are awake. Usually it's when they're trying to fall asleep. And then the last feature of narcolepsy we need to talk about is sleep paralysis. So this is the temporary inability to move or speak. In patients who have narcolepsy, this usually happens when patients are trying to fall asleep or when they're just waking up. And it usually lasts only a few seconds to minutes, but it's very frightening for the patient to be unable to move, even though it's not dangerous and patients usually are able to breathe. And once again, the reason this happens is because you've got features of REM sleep, which includes loss of muscle tone and paralysis that are intruding into periods of wakefulness. The diagnosis of narcolepsy is usually made in a three-step process. The first step is to identify typical clinical features, and these are things we've already talked about, like excessive daytime sleepiness for more than 3 months, and other things like cataplexy, hallucinations, and sleep paralysis. Once you suspect the diagnosis based on clinical features, the first test that's usually done is an overnight polysomnogram. That's what's shown here in this picture. It's basically an EEG recording along with pulse and oxygen saturation as the patient sleeps. This is done not so much to diagnose narcolepsy, but to rule out other disorders. So patients with narcolepsy, when they are asleep, should have normal sleep architecture, and you also want to make sure they don't have another sleep disorder like obstructive sleep apnea. So all these things are established by overnight polysomnography. After that, the next test that's usually done is called a multiple sleep latency test, or MSLT. This is a test done during the day to determine how quickly the patient falls asleep when they decide to have scheduled naps. This is often done the day after the overnight polysomnography test we talked about in the last slide. And in patients with narcolepsy, the MSLT test will show 3 findings, which I've listed here. First of all, for a scheduled nap, they will have short sleep latency, which means less than 8 minutes. This basically means that they fall asleep very quickly for a nap during the day. Once they fall asleep, they will enter REM sleep very quickly after falling asleep. And then lastly, they will experience episodes during their naps called SOREMs, which are sleep onset REM periods. They will have multiple of these during their sleep latency test. And so these 3 things are the findings to diagnose narcolepsy. And then lastly, I mentioned this before, but a lumbar puncture can sometimes be done. It's often unnecessary. But if the diagnosis is uncertain, you can measure the concentration of hypocretin 1, also called orexin A, in the cerebrospinal fluid, and it will be low in patients who have narcolepsy. And so I've sort of summarized these things on the slide here. You suspect narcolepsy from clinical features, you do an overnight polysomnography or sleep test, then you do the MSLT, and only if the diagnosis is uncertain after that do you do the lumbar puncture to try and identify low hypocretin level. The treatment of narcolepsy is complex, but I've listed some of the key elements on this slide. So first of all, good sleep hygiene is important. These patients are advised to take scheduled naps if they can so that they don't suddenly fall asleep during the day, and to maintain a regular nighttime sleep schedule. Beyond this, stimulants are sometimes used to keep patients awake during the day, so amphetamines can be used. These are drugs I talk about in other videos. They increase dopamine and norepinephrine activity in the central nervous system. There's also a drug called modafinil, which is sometimes used for narcolepsy. It's a dopamine reuptake inhibitor, and it's just going to boost dopamine activity in the central nervous system to try and stimulate patients and keep them awake during the day. And then lastly, there's a special drug sometimes used for narcolepsy that patients take at nighttime called sodium oxybate. It's also called gamma hydroxybutyrate, or GHB. This drug improves slow wave deep sleep, that N3 sleep that's restorative at night. And so after taking this drug, patients get a better night's sleep, and this can reduce daytime sleepiness the next day. It's also been shown to reduce episodes of cataplexy. Okay, our last disorder for this video is restless leg syndrome, which refers to an uncomfortable sensation in the legs that causes patients to feel like they have an irresistible need to move their legs. This sensation emerges during periods of inactivity, especially when patients lie in bed at night and try to stay still so they can fall asleep. They will feel like they constantly need to move their legs. The sensation of feeling like they need to move their legs is improved by walking. However, when patients are trying to fall asleep, they don't want to get up and walk around just to make this urge go away. This is usually idiopathic. We don't really know what causes this, although there may be a genetic predisposition. Some patients who have this have a family history of the disorder. And the diagnosis is entirely clinical. MRI or other studies of the brain are not indicated generally and don't need to be done. The most important thing to know about restless leg syndrome for your board exams is that it can occur secondary to iron deficiency. The reason for this is poorly understood, but a number of patients who have restless leg symptoms are deficient in iron, so we almost always check an iron level when patients have this diagnosis. And if you treat the iron deficiency, restless leg symptoms sometimes go away. Restless leg syndrome can also be secondary to other things like chronic kidney disease or diabetic neuropathy. It also can come on with pregnancy and get better when the pregnancy is over. If you can identify an underlying cause like iron deficiency, then the treatment is to treat the underlying disorder. And so be aware of this in a board question. If they show you someone with restless leg syndrome, the treatment may be iron supplementation if that patient has iron deficiency. Beyond treating the underlying disorder, there are a number of non-pharmacologic measures that can help. So if patients get regular exercise, they often have less restless leg syndrome symptoms. It can also help to massage the legs. Hot or cold baths can help. And then avoiding things, especially close to bedtime, like caffeine, alcohol, or nicotine, can also improve symptoms of restless leg syndrome. Now, all those things on the last slide are helpful in mild restless leg syndrome, but when patients have moderate to severe symptoms, the first-line therapy is with drugs. And there are two groups of drugs that are used to treat this condition. First are the gabapentinoids. These are the two drugs, gabapentin and pregabalin. I talk about these drugs in detail in the video on seizure disorders. And then there are two drugs which are dopamine agonists. Those are pramipexole and ropinirole. And so both of these drugs have also been shown to improve symptoms of restless leg syndrome. And that concludes our module on sleep disorders.